Our next speaker this morning is Michael Walsh. He did his medical degree and residencies in internal medicine and nephrology and a Master of Science in Clinical Epidemiology at the University of Calgary. He then completed a fellowship at Cambridge before coming to McMaster to pursue a PhD in health research methodology. He's currently an assistant professor in medicine and nephrology and clinical epidemiology and biostatistics. And his research interests include the treatment of patients with end-stage kidney disease and patients with complex autoimmune diseases. His topic this morning is the fragile study, Can You Believe Its Results? Michael Walsh.
Well, it's a huge honor to be able to speak here. I'm an epidemiology nerd, and it's like getting to visit the All-Star Hall of Fame and get to play in the All-Star game now. So I have no real potential conflicts of interest, although I did declare that I've received research support from various pharmaceutical companies. So I feel now after the first talk that we're not really debating observational versus RCT. We're debating a bit about large versus small, and that's good because I'm probably not going to inform observational versus RCT very much in my talk. I'm going to say just that good observational studies are probably good for some things, and good RCTs are probably fairly informative about treatment effects, good for some other things. But what's good is not always clear. And I'm going to start from the position that I started in years ago when I was a first-year resident, where randomized plus a p-value of less than 0.05 equaled truth, which is probably something that many of us who are now deeply enmeshed in methodology have a difficult time believing we may have once actually believed. So to put this into context for the David Sackett lecture, this was actually my first introduction to David Sackett. The point of this slide is not to suggest that I have enormously large hands. It's to suggest that I first was introduced in about 2001 when I started residency, and mini CDs were all the rage then. So I got my first evidence-based medicine book on a mini CD, and it was Dave Sackett's Evidence-Based Medicine. And in it, I learned that random allocation is really important, deciding what a good study was for an RCT, that concealing the randomization list was important, that we had to look whether or not a study had sufficient follow-up, we had to check whether or not analysis of all the patients was in their allocated group, we had to ensure that blinding was done if it was appropriate, and that the treatments were equal across time, and that patients had a similar prognosis at the time of randomization. And I present these as a checklist because that's exactly what I did in 2001. I would go through a study, and so I was presenting it for Journal Club, and I would check off all of these things, and if I could check them off, then I would say that was probably a good study, and we could go on to look at whether or not the results were significant. But it's not necessarily that straightforward, and I didn't appreciate that at the time. Concealment is sometimes difficult to judge. It's unclear or inadequate in almost 50% of studies, even in high-impact journals. Sufficient follow-up is often difficult, and we don't know about what sufficient means until we look in the retrospectoscope to figure out what's happened in long-term follow-up. Analysis of patients in their allocated groups. The term ITT has been used in 1,000 different ways. 48% of studies stating ITT, of which only 17% did, and 75% were actually unclear. Blinding can be variable, and it can have an unclear meaning when it's actually used in studies. And a similar baseline prognosis can be very difficult to establish because often we know very little about what actually contributes to their baseline prognosis and how much that will be balanced in a Table 1. And then we have to consider the effects of spin and publication bias, which may all contribute to whether or not the study was published and whether or not we'll be getting the clear message out of it. And it goes on. There's multiple ways of presenting the effect estimates from a study, some of which may have different psychological impact from others. And there's too much information. Many therapies turn out to be less effective than initially reported, and there's exponential growth of RCTs that makes it difficult to keep up with the literature. I'm a lowly nephrologist, and if you look at this graph that Giovanni Strapoli put together of the amount of published RCT data coming out on an annual basis for each of the internal medicine specialties, nephrology is way down here. But even then, it's 200 studies a year, so I have to catch up on the last decade's worth of literature, and then I have to try and contend with another 200 studies a year, which means I have to try and interpret one RCT every day to try and stay on top of my field. It's enough to make your head explode at the end of the day. There's just too much, and there's too much detail to try and go into. So we need an effective triage strategy. And this is where modern statistics, I think we often feel, comes to the rescue, particularly for the busy clinician or other knowledge users. So this is a cartoon. Somebody runs in and says, "This just in, jelly beans cause acne." Scientific director says, "Scientists, investigate." They complain, but they go ahead and do it, and they say, "Well, we found no link between jelly beans and acne because the p-value was greater than 0.05. Director says, "That settles it." Same person comes back and says, "But it's only a certain color." Scientists go to it again. Scientists look at, not by random, all 20 different colors of the jelly beans. And in fact, there was a link between cyan jelly beans and acne. I'm one over. It's actually green jelly beans and acne. P at less than 0.05. And the news picks up on it immediately. Green jelly beans linked to acne, 95% confidence, only 5% chance of coincidence. Now, this is a cartoon, but I think this is actually fairly reflective of what RCTs are actually evaluated like in the public. Stuart Pocock said back in 1985 in the BMJ that the accept-reject philosophy of significance testing based on the magical 0.05 barrier remains dominant in the minds of many statisticians. We're now 2 decades later, and I don't think that that has actually appreciably changed, at least in my interactions with my clinical colleagues, and oftentimes I have to catch myself doing the same thing. So again, a little cartoon. Lightning strikes. One individual says we should get inside. The other one says it's okay. Lightning only kills about 45 Americans a year, so the chances of dying are only about 1 in 7 million. Let's keep going. It says the annual death rate amongst those people who know the statistic is 1 in 6. And this is Daniel Kahneman. I couldn't find a good picture of Amos Tversky, unfortunately, who are very influential in finance and economics, but they were also psychological statisticians. And they did some really interesting work in the 1970s, which I think we all intuitively know, is that people are not really good intuitive statisticians. We tend to believe in small numbers. We tend to develop heuristics about the representativeness of presented data, and we extrapolate unfairly. So the question then becomes, how can we make the believability of a treatment effect more transparent? There's lots of things to consider. We need to wade through the information fairly quickly. And the triage point of a P of less than 0.05 may or may not be correct. So one of the proposed solutions has been 95% confidence intervals, or other confidence intervals of varying sizes. And sometimes that can be a fairly clear comparison of treatment effects. In this example, all of the confidence intervals are the same width. Some are closer to the null value than others. I think a fair interpretation by many people would be that the one that's the furthest away is the most likely to contain a true and large treatment effect and would be the most worthwhile therapy. But this can get a lot more cloudy. We get confidence intervals that are of varying sizes and distances from the null value, and it becomes murky for the knowledge user to actually interpret which is the best therapy or which is actually an effective therapy. Another proposed sample comes from Dr. Youssef in a very interesting piece of work from 1985, which demonstrated that in cardiovascular trials, 650 events were required to require a definitely adequate amount of information before a firm conclusion could be reached, based on some fairly standard assumptions that fit a large number of chronic cardiovascular conditions. Christian Thorlund did a modification of this type of work in meta-analyses that looked at very similar assumptions about baseline risk and likely treatment effects, and demonstrated that for the common scenario of a 20 to 30% relative risk reduction, about 650 events were also required in order to avoid significant overestimation of effect. Now, the immediate rejoinder to this from many people will be that the baseline assumptions don't fit my disease group. The relative risk reductions may be higher because I'm treating a disease that has very few effective therapies, or the relative risk reduction may be quite a bit lower because we're dealing with very simple adjuvant therapies in diseases that have good outcomes, or that the baseline risk may be dramatically different. And that makes it difficult for people to apply uniformly across trials. So Alvin Feinstein proposed another metric, something called the unit fragility, in which he looked at the relative change in an effect size if one unit was transferred between a 2x2 table, keeping all the margins constant. So essentially, one event in one group became an event in the other group, and a non-event in the group it started out in. And then you could make a comparison in the shift of this relative effect on the minimally clinically important difference and the threshold for statistical significance, which Stephen Walter elaborated on in 1991. This is actually, it's a very elegant piece of work. It looks very nice. The paper presents it in a great way. But it hasn't really caught on in reality. It's been almost 2 decades. So why has it not caught on? I think perhaps there's some difficulty in framing changes in relative effect sizes. In general, actually the consumer of the event of an RCT as a clinician has difficulty figuring out what big and large effects realistically are. It's also difficult determining widely accepted minimally clinically important differences for many outcomes, and that makes the relative changes also very difficult to put into context. Perhaps, though, maybe some of this is just that it wasn't widely advertised, and that could have been why it wasn't broadly taken up either. Recently, we proposed a slightly different take on the unit fragility we named the fragility index. And this is a similar concept where instead of shifting between treatment and control, we just add cases onto the treatment group, assuming that the treatment or the outcome is something that is unwanted or bad for you. And we keep on adding those until we get to the point where the magical boundary for statistical significance is lost. And we ask, how big was that number? How many events did it take? And that number then becomes the fragility index. The higher the number, the more robust the result was. So if we look at an example of a trial that was conducted that was powered for a 33% relative risk reduction that sounded like it was plausible from previous literature, it was done under the assumption of a control event rate of 12.5%, and the actual event rate was 13.8%. There was 90 deaths in the treatment group and 118 in the placebo. They measured a 24% relative risk reduction with a confidence interval of between 1 and 43% and a p-value of 0.04. It was a reasonably large trial. There was a reasonable number of events. But in reality, it only took 2 events to overturn the nominal statistical significance of that trial. And I think that people's belief would have changed if they had known that. We can look also then at comparing 2 different therapies in a similar manner. One in which a drug reduces the incidence of MI by 89% in the treatment group with a very broad confidence interval, but a p-value of 0.02. Another trial that's much larger, over almost 500 events, the exact same p-value, or very close to the same p-value, and relative risk reduction of 20% with a confidence interval of 4 to 33. And some might argue on the basis of the confidence interval that in treatment A, it's further away from the null value. There's less likelihood that this is actually an incorrect result. But it only took 1 event to shift that confidence boundary over the null value, to shift the p-value over the magical 0.05 threshold, and perhaps to shift people's beliefs about whether or not that was a reasonable intervention. Similarly, in trial 2, it took 9 events. Now, you can start to debate whether or not 9 is a big or a small number here, but it's definitely different than 1 event. Now, statisticians always shake their head at me as soon as we go through this. It's a lot of silliness. There's no validity to that, and we have to start playing with some hypothetical situations. So if we start to do a simulation where we say that investigators have dreamt up a trial where they believe that there's a 20% relative risk reduction, and they want 80% power to show this with an alpha of 0.05. The baseline risk for this condition ranges between 20 and 50%, and then the appropriate sample sizes come up between somewhere in between 800 and 3,000 patients in total, so 400 to 1,500 patients per group, in order to demonstrate this effect. In reality, however, we can say that the true treatment effect is either there is none, there's a small or a 10% relative risk reduction, or a moderate or 20% relative risk reduction, and that this would give us somewhere between 300 and 600 events in total. So if we look at where this then lands us up for a fragility index for each one of these scenarios, in trials that are pretty close to the truth, so there is in fact a 20% true relative risk reduction with that treatment, the fragility index is very rarely below 9. For studies in which there is a small treatment effect, when in fact they assume there was a large one, and we take the positive studies out of that, they overestimate modestly, so there really is a treatment effect, but it's not as big as has been estimated. There's rarely a fragility index under 4. And for those where there is no true treatment effect, but they have found a treatment effect, it suggests that, that there is frequently a fragility index that is under both of those values, 9 or 4, and typically under 9. So empirically, does that play out in real life? Well, it's harder to tell, and we're still working on that. But if you were to look at 399 trials that had reported a statistically significant result in their abstract in top medical journals, 25% of those would have a fragility index of 3 or less, and 50% would have a fragility index of 9 or less. That's a large number of trials that are potentially relying on small numbers of events to drive what people will believe is a real treatment effect. Whether or not, as methodologists, we believe there's a real treatment effect may differ. I would put forward that the vast majority of consumers of medical literature, this will be their first triage point towards belief. So is this plausible? Is it actually likely that someone would have missed 3 events in one group? I think the longer I've worked in trials, and it's a very short amount of time compared to many people in this room, the more I believe that things can go wrong and that it's hard to sometimes detect when things can go wrong. So loss to follow-up is often greater than just a few patients, and it's often unclear whether or not this is a random process, and it's unclear what's happened to those patients. Post-randomization exclusions has been one thing that's really bugged me about trials that I've worked on in the past before I've understood anything about methodology. Again, patients that we don't know what's happened to, and we're unclear what the effect of the treatment might have been. Incomplete or inadequate blinding, very common. Subjective outcome assessments that may deeply affect whether or not we think that an outcome has happened that's affected by a blinding. Differential co-interventions by incomplete blinding, all very possible in a large number of trials. And then there's just strange things that happen in trials. Anything that can go wrong seems to go wrong. I've worked on trials where people have gotten the sex of the patient wrong for 15 years, and it's not until after we've reviewed the trial documents and the patient record years later that it's been found. I'm not saying that happens all the time, and that's maybe a bit of a big mistake that happened, but anything can go wrong, and our ability to detect the things that go wrong is probably quite limited. So, I think we should probably, as a medical community, be conservative in our belief about treatment effects, because so often they're overblown, they're later overturned, they're based on unrealistic relative risk reductions. Statistics can certainly help us determine our belief in a treatment effect, but they're fallible, and it's fallible to believe that the average clinician will be able to accurately interpret statistics. Several options for figuring out whether or not our tests are likely to be misleading exist, and I would put forward that we need something that's simple and intuitive to help people decide whether or not they should believe or should have some degree of skepticism about whether or not a treatment effect exists. I'd like to acknowledge that P.J. Devereaux, David Sackett, and Gordon Guyatt were very helpful in delivering me onto the fragility idea. And there are several individuals who really helped guide the process in figuring out how to make it work. And I'll leave you to try and preempt Bayesian questions. I will leave you with a Bayesian cartoon. So the question is, did the sun just explode? It's night, so we're not quite sure. So we've made a neutrino detector that measures whether or not the sun has gone nova. Then it rolls 2 dice, and if they both come up 6, it lies to us. Otherwise, it will always tell us the truth. So we'll try it out. Detector, has the sun gone nova? Rolls its dice and says yes. The frequentist says, the P was less than 0.05, I conclude the sun has exploded. The Bayesian says, I bet you $50 it hasn't. And with that, I'm happy to take any questions.